Warm greeting to you all. This informative video about endometrial osseous metaplasia as a rare cause of infertility is brought to you by Dr. Birish, gynecologist and endoscopic surgeon, Bangalore, India. A 28-year-old lady presented with history of secondary infertility. Previously had spontaneous miscarriage at 12-week and was terminated by uterine instrumentation due to incomplete evacuation with medical management. On evaluation with transvaginal ultrasonography, showed a hyperechoic elongated lesion measuring 2 centimeters x 1 centimeter in the endometrium, suggestive of endometrial calcification with posterior acoustic shadowing. With this, she was subjected to hysteroscopic evaluation. Given its low incidence, EOM is often a source of misdiagnosis, being mistaken for intrauterine devices, Asherman syndrome, calcified submucosal fibroids, endometrial cancer, and Müllerian tumor. Hysteroscopy is a key tool for endometrial metaplasia management. It appears as osseous lamella, white in color, fan or disc-shaped, and embedded in the mucosa, or as an intracavitary structure. In this hysteroscopy was performed with vaginoscopic approach using 2.9 mm forward oblique hysteroscope with operative sheath and normal saline as distension media. On soft entry into the uterine cavity, flat lamellar bony tissue was noted arising from posterior endometrium. Rest of the uterine cavity was inspected and found to be normal. To ensure complete removal, bony fragment was separated from endometrium with hysteroscopic scissors. Lateral cut on the uterine wall was made to visualize the right ostia. Rest of the endometrium looked normal, and no signs of endometritis was found. As the size of the lamellar bone was larger than the internal os, it was pulverized into smaller fragment and was extracted in smaller pieces with the help of hysteroscopic grasper. Finally, endometrial sampling was done and the procedure was concluded. In patients with extensive plaques of EOM and bone fragments embedded in the myometrium, where satisfactory hysteroscopic removal is difficult, the usefulness of laparoscopic control during the procedure has been highlighted, which allows for greater accuracy and minimization of risks and complications such as uterine perforation. Novel technique of percervical uterolithotripsy, techniques undertaken for the percutaneous management of upper urinary tract stones and treat the bony tissue, has also been reported in literature for removal of extensive EOM. After osseous fragments removal, spontaneous pregnancy can be expected within 1 year following the complete restoration of the endometrial cavity. As per evidence, 55.6% of the infertile patients achieved a pregnancy. Histopathological examination revealed bony tissue fragments composed of mature and woven bone. Endometrium shows fragments of late secretory endometrium. Coming to the discussion. Endometrial osseous metaplasia, hereafter referred as EOM, is a rare condition characterized by the presence of mature or immature bone in the endometrium. In the literature, variously described as endometrial ossification, ectopic intrauterine bone, or heterotopic intrauterine bone. Age, seen in women in their reproductive years, although it has been reported in the menopausal years as well. Clinical features. No specific symptomatology, but EOM could be associated with infertility as bone in the endometrium acts like intrauterine contraceptive device, menstrual irregularities. Theories 1. Implantation of fetal tissue after abortion and instrumentation, as 80% of the cases have history of previous miscarriage. Time interval between antecedent abortion and the detection of endometrial ossification varies from 8 weeks to 15 years. 2. Metaplastic transformation of pluripotent endometrial stromal cell with induction of osteogenesis. Comparative DNA analysis of bone fragments from the lesion and surrounding endometrium are same inferring maternal origin. It is now accepted that the remaining embryonic or fetal tissue induces chronic endometritis. This phenomenon is responsible for the release of pro-inflammatory compounds, especially cytokines, as tumor necrosis factor alpha and free superoxide radicals. These compounds can induce the metaplasia of endometrial pluripotential stromal cells to form osteoblast. However, why only an extremely small number of abortions are followed by EOA remains unknown. 3. Metabolic disorders: hypercalcemia, hyperthyroidism, hyperphosphatemia, or hypervitaminosis D. 4. Genital tuberculosis, unspecific chronic endometritis, or pyometra are other sources of chronic inflammation diagnosis and treatment. The first step in EOM diagnosis remains ultrasound due to its availability, wider acceptance, and being a non-invasive procedure. Sonography shows a hyperechoic lesion in the endometrium, suggestive of endometrial calcification with posterior acoustic shadowing. Hysteroscopy, followed by pathology, established the final diagnosis. Due to its rarity, this entity is estimated to be present in only 0.1%, that is 1 in 1,000 of all hysteroscopies. The hysteroscopic resection of the endometrial bone corrected the menorrhagia, and a spontaneous, uneventful pregnancy occurred. Very probably, the infertility was the result of EOM. This conclusion was supported by the lack of any other abnormal finding during clinical and laboratory investigations, and by the successful pregnancy after the extraction of the calcification. Thank you for your watching. Hope this was informative. Subscribe and watch this space for more informative gynae endoscopic video.